Hi, my name is Trina. I'm from Respiratory, and today we're going to talk about respiratory care and how it pertains to nursing. So first we're going to start with FiO2 and flow. FiO2 is something that we use all the time when we're talking about oxygen and devices, but we don't always quantify it in those terms. We don't say FiO2 of 25%, we say 1 liter of oxygen. And so I'd like to kind of clarify what those terms mean. So starting, we have flow meters, right? These are devices that measure how much gas we're using and how fast it's coming out. When we turn these little dials on the sides, what that does is it's opening up a valve and it's allowing more gas to come through. And as we're measuring it, we do that in units of liters. So 1 liter per minute, 2 liters per minute, 3 liters per minute. That's measuring the flow that is coming out of these devices. And so when we're discussing the oxygen concentration, we use a term called FiO2, fraction of inspired oxygen. When we have room air, so this is a flow meter for compressed gas called room air, which we're breathing right now, and the oxygen content, or FiO2, of room air is 21%. No matter how high I turn this flow, no matter how fast this gas is coming out, the O2 content is always going to be 21% oxygen. Whereas if I'm using this gas, so this is oxygen, every time I open up the valve, we get more and more flow. With more flow of oxygen comes higher concentration of FiO2. So baseline, we're at 21% room air. Every time we increase by a liter of flow, we add another 4% to that 21%. So for example, let's say our patient is on 1 liter of oxygen. We start 21 plus 4, that's 25% FiO2. We go to 2 liters, so we increase another liter, we add another 4%. So we bump up to 29%. Another liter, another 4%, another liter, 4%, liter, 4%. And that's why our saturations on the monitors are changing, our O2 sats, is because we're increasing the concentration of oxygen within the gas that we're providing. When we, and I guess that's a great time to explain that using oxygen is not going to change the way a person is breathing. It is merely going to increase the oxygen saturation. And so when we are utilizing devices here, so we have our non-rebreather, we have an oximeter, we have an oxymask, we have high flow oxygen via nasal cannula. All of those will help with hypoxia, our hypoxic patients with low saturations, but those are not going to do anything for the way in which they're breathing. So if your patient is short of breath, if they're having any difficulty breathing, they're exhibiting signs of perhaps distress, they can't finish a sentence, they are tripoding, they are diaphoretic, they're using pursed-lip breathing, they're cyanotic, these are all indications that our patients are having difficulty breathing, which is leading to their hypoxic state. If that's the case, now what we're gonna do is move from this passive flow, meaning we're just using the flow to get them the oxygen. Now we're going to go to something that's more precise, and we're going to do that with a heated high flow nasal cannula. And so this device is called optimal humidity. Optimal humidity is a heated humidified nasal cannula that is at the perfect internal temperature for our patients to receive it, because oxygen that comes out of the wall, like we hook up to a flow meter, that oxygen is cold and dry. And if we were to try and attempt to deliver 20, 30, 40, 50, 60 liters of flow with cold, dry gas, we would actually cause damage to those patients' airways. So we are not going to do that. We are going to heat it, we are going to humidify, and then we're going to provide that to our patients in the hopes that increasing that flow is going to help with shortness of breath. It's very similar to when, if you've ever had a patient that you're settling in the room and they're just short of breath, they can't catch their breath. They're like, put a fan on me, I can't breathe. And you put the fan in their direction, and now it's easier to breathe. You have satiated their air hunger. You have provided airflow that is now allowing it to be easier for them to breathe. They're not as taxed to do so. So on this machine, we have two things. Besides the heated humidity setup, we have, that's okay, that's okay. We have two controls here on the side. We have oxygen and we have flow. So instead of just cranking up a flow meter and doing the math and based on the way a patient's breathing, are they getting that much FiO2? We're not going to mess with that. We are just going to dial in exactly what we want. So our top dial is for oxygen, FiO2. The bottom dial is for our flow, 20, 30, 40, 50, 60 liters of flow. We never go above 60, hard and fast rule. We don't do that. Usually we're going to start around 40 liters and go up. If they need more support, we might drop it down a little bit to like 30, but usually we don't go too much lower than 40. So that's a pretty standard setting. So we'll dial in our flow. The flow is measured here. So that flow meter tells you how much flow you're using. Your FiO2, or the oxygen concentration, is going to be displayed right here digitally. So if we're on room air, I would expect to see 21%. We might go up to 30%, 35, 40, 45, 50. I like to go by increments of 5% or 10%. If I know for sure that they need more than just 40%, if I know like, hey, this person saturations are very low, you are allowed to go up and come down. So don't be afraid to do that. Nurses are able to titrate, change, adjust any oxygen parameter on any machine. You are allowed to change FiO2 on any device we're using. Now, if it is flow, if we think flow is the issue, please leave that for RTs. And if we're talking about pressure, like with a BiPAP, we want to leave pressure changes for RTs as well. However, you as a nurse are able to change the FiO2, the oxygen part. So this is, let's see, bear with me. Okay, so this is our BiPAP machine. And what we're seeing here on the display, try and get rid of that glare. Okay, so our machine has a few different settings. On the bottom here, it tells you what inspiratory pressure we're using, expiratory pressure we're using, because remember BiPAP meaning two pressures. Pressure on the way in, pressure on the way out is a little bit less, which was gonna allow us to take that big breath in and then exhale a little bit easier, allowing for us to flush out extra CO2. If you've ever heard the term blow off CO2, that's what that means. It means that you're exhaling and you're blowing out. So we increase the respiratory rate, we allow more CO2 to be expelled from the body. We also have a backup respiratory rate. That is merely there to keep us informed if the patient were to become apneic for a prolonged period of time, meaning like their respirations are low and they're not initiating any breaths. We are going to look to that if it alarms, because that lets us know that perhaps their respiratory state has changed. The last value we see here is FiO2. So FiO2, again, on any of the things that we're using, nurses are able to adjust the oxygen concentration to achieve our saturations on the monitor. So to change the FiO2, tap, turn, tap. And that's going to change our overall FiO2. Let's say you don't necessarily want to change the underlying FiO2, but you do want to give your patient an oxygen boost. The way we do that, it's going to be a little out here, that's our silence button. Right down at the bottom, it says elevated O2. We're going to tap that button. It opens up a window. Now, don't be alarmed. Right away, you see 79. And if you're like me, you're like, no, I want 100%. Well, I had to stop and think. 21 plus 79 gives us our 100%. So this will always be 100% as a default setting. And then we also have 2 minutes of hyperoxygenation, so that 100% oxygen we're delivering will last for 2 minutes. If I want to make it a shorter duration, I certainly could, but 2 minutes of 100% is not going to hurt anyone unless we're talking neonates. That would be the exception, but for adults, 2 minutes is totally fine. CO2 retainer or not, that is not going to create any kind of issue. Now, we press start and this button has turned blue, so that's letting you know, oh hey, you're giving 100% oxygen and this is gonna last for 2 minutes. Then that light is the blue is going to turn back to the way it is without, and so you know that 2 minutes is up. It's okay if you have to hit that oxygen boost more than once. But if you're having to do it multiple times in a row just to maintain your O2 sat on the monitor, that is probably indicative of lungs that are less compliant, in which case we would want to look at perhaps pressure is an issue. So call your RT and let us know, hey, I've been hitting this O2 boost a few times. Could you please come check out the machine and the patient? And so truly there's no problem in giving those oxygen boosts. It is absolutely, again, we tip room air is 21%. So even if we're at 40 and 50%, it's not really that much oxygen if you think about it out of the potential 100% that it could be. Now, if I want to put this machine into standby, I'll hit standby and then it says move to standby. Yes. Confirm. It goes to sleep and you're able to give meds if you need to. The one thing I will point out is if you're going to give your patient pills and they're drinking water, make sure that after they take that last sip that you have them cough or clear their throat just to make sure there's nothing in their mouth that with the addition of positive pressure could get pushed into their lungs. So we just want to be mindful of that. But when you're ready, you can put the mask back on, resume ventilation, and it goes back to those settings that we already had. All right, come with me. We're gonna go down the line here. Okay. So now, forgive me, let me try and get a better angle here. Okay, so we are talking trachs, and actually before we do that, let me do something else. Okay. Slippery fingers. All right, so this is incentive spirometry, right? We all know this, we love it, it's our favorite. A few things to point out, that there are 2 different points of interest for us as we're watching our patients and encouraging them to take these deep, slow, deep breaths. The first is the measurement of the size of the breath, and we are measuring that in milliliters. And so what we do is based on a patient's height, their age, and then also their gender at birth, will tell us what size breath to expect and where to put their little piece here, our goal. Now, that is all neatly defined for us in a chart that is a piece of paper that's included in the packaging for these devices. And if you're like me, I have a tendency to open it up and perhaps just throw it away. So be mindful that if you don't know what the patient's goal is already, to take a look at that chart and determine based on their age, their height, and then gender at birth, what our goal volume would be. So for me, I know I'm 5'5" and 3/4, almost 5'6". My goal is about 1,800. And so I would expect that on my good days, I would be able to reach 1,800 doing a slow, deep breath and holding it. Now, our patients come to us and they're sick, right? Or they've had surgery, and so they are not going to be at their peak performance. And keep that in mind, because we want to be sure that we're encouraging them, but we're not pushing them towards an unrealistic goal. So, slow, deep breath, right? And hold. The goal is to just float this little plunger in the good, better, best. It's actually difficult to do. And so if a patient does this, did they achieve their volume? Yes, absolutely. Was it a sufficient breath hold to do any kind of expansion therapy over a long period of time? No. So if you're going to have your patient do these, make sure it's slow, deep breaths and that they hold it. And that is going to help over time lead to progressively more compliant lungs. If your patient, you ask them to take a big deep breath and they go like this, and you're like, okay, now try and breathe in. Okay, this is not going to work. You can talk to respiratory, you can give us a call, or you can talk to doctor yourself, and we could utilize a device called PEP, positive expiratory pressure. And so this does the same thing as IS for expansion therapy, except they get to exhale. They don't have to take a deep breath in. They can do a prolonged exhalation, and that pressure is going to go back to their lungs. Promote expansion, recruit alveoli. Now the alveoli are plump and able to exchange gas. O2 saturations will go up because the alveoli can do their job. So this is what it looks like. And a prolonged exhalatory phase will do the same thing as a prolonged inspiratory phase. It does require an order, so either you may ask doctor or you can have RT get that order from doctor, but this is a great alternative to IS, and in addition, for any kind of lung expansion we need to do. The other device that RT has that you may have seen, this is called an acapella, and this is for pulmonary hygiene or toileting. They say pulmonary toileting. I don't know. I like hygiene better, so we're gonna just try and keep the airway clean. If you've ever seen an RT cup their hands like this and do some chest percussion, this does the same thing, but it's from the inside out. So when a patient exhales forcefully into it, it creates vibrations. Those vibrations come back to the person, they reverberate, shake all the phlegm on the lungs in the hopes that when they cough, they can then expectorate, spit it out. So it sounds like this. And you can hear that chugga, 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 chugga. Those are vibrations that are knocking around inside my lungs. This too requires an order, so you may ask doctor if you feel like they have some rhonchi going on, there's just junk in their lungs. This is an awesome addition for those types of patients. RT can get that order as well, and we round on this, typically QID 4 times a day. But that's not to say that if the patient could be independent, we may decide to turn it over to them. All right, good. You guys are doing great. Okay, then last thing, we're going to talk about trachs. So we've seen a lot more trachs recently, and I just wanted to review a few of the different components when we get a trach. So this is what it comes in, this little box, and when a patient goes to surgery, there's 3 things inside of this trach box. You're going to have the airway itself, that's the trach. You're going to have a hard, pretty rigid, what I like to think of as a guide wire. This is called an obturator, and the obturator needs to be inside the trach when we're going to insert it into the patient's airway. And the reason is because the bottom of the obturator is domed like that, and so it's not going to cause damage to the tissue of the airway. If we did not have that, you can see how this is very blunted. It's actually quite sharp. It's similar to if you've ever used a melon baller or an ice cream scoop. If we drag this along their tissue, we are going to cause them damage. So we need to have the obturator inside before we attempt to place the airway. Once that airway is placed, now we're going to remove the obturator. This will now only be necessary if we are inserting the trach. It's important to keep track of it though, because you need it in case this comes out and you don't have a backup trach. Do not lose this. This is the first thing you're going to ask about accepting a patient with a trach. Where is their obturator? Don't lose this, okay? The other piece is called an inner cannula. So an inner cannula goes inside the airway, and it just kind of snaps in there. And it allows for us to keep not only a patent airway, meaning it's open, but it also allows us to keep it clean. So those secretions, anything that's going to collect in that airway, the inner cannula is a nice barrier to the device itself. I always think of, at Thanksgiving time, we use crock pots in my family quite a bit. And my mom always uses this clear plastic liner inside. And I never really understood it until it makes total sense. You can cook inside of that, and then you just take it and throw the liner away. It's disposable. This is exactly the same thing. This is a liner to keep your airway clean. So this is disposable. This is not. Okay, so we take these out. Trach cares are typically every 8 hours or so, certainly once a shift. And cooperatively between RT and nursing staff, we'd like to move to doing those cares either together or at least communicating when they need to be done, who will be doing them, and how we go about doing that. Another version of the same thing would be this trach. And again, it has stylet type device called an obturator. Hello, obturator? Okay, now try and forget that. So it goes inside. Again, it's a round edge instead of this real sharp, blunted. So we're gonna place our airway, take out the obturator, and then we're gonna insert our inner cannula. Now this type is a little bit trickier. I'm trying to get the right angle because of these clasps. They're like little angel wings, and we need to pinch them together to get it to snap onto the front of this flange. Now, if you've never used one of these and you would like to handle one, I have extras. So just talk to your educator and I can drop them off for you to handle. But essentially, you're gonna pinch these little angel wings and it snaps right in there. I like to brace my trach flanges with my opposite hand when I use this kind specifically, because then I can push against myself instead of pushing into their neck. Okay. This trach has fenestrations. Those holes that we see here, those are called fenestrations. This trach is non-fenestrated, meaning there's no holes. And these holes allow for air movement, not only the typical in and out of the trach, but also for air to pass up into the upper airway, which is where our vocal cords are. Our vocal cords are here, and the trachs are typically distal. They're going to be distal to the cords. And so if the air is only moving in and out of here, your patients can't talk because there's no air going up through the cords and out. So that's why they're not audible. But if they cover their trach and now they can talk, it's because they're pushing air through their cords, through the vocal cords. This type of trach is called, first we have fenestrations, right? But this trach is cuffed, all right? And a cuffed trach means that there is a balloon at the end. So I'm going to put air into this little pilot balloon, and it's going to inflate, let's see if I can use my shirt, a cuff. So now this is cuff up, meaning inflated. This is cuff down, so it's deflated. Our patients might be cuff up when they're on a breathing machine, so a BiPAP or a ventilator. They might also be cuff up if they're at risk for aspiration, so where they're having tons of secretions that they're actively aspirating. This cuff will protect the airway, so any of that has come down will be trapped here, and it's not going to sink further into their lungs. It's not perfect, but it's a reason why they might do that. When a patient comes out of surgery and they're on a ventilator, they're going to be cuffed, cuff up. When we get them off the ventilator, they're going to be cuffed, cuff down. Okay, and then we might do a tube exchange. So we might downsize our trach. So we might go from a 6 Shiley to a 4 Shiley. And those numbers are telling us the size of the trach itself, because the goal is it requires tapering to get it in. And so we taper to let it heal. So we'll downsize our trachs until we're ready to decannulate, meaning remove the trach altogether. The hole that's left in their neck is called a stoma. If there's an artificial airway placed, that's called a trach. Those are the differences. And when we're suctioning a trach, we do not need to use any kind of lubrication. No lube with a tube. And so typically the trach, you can kind of see how big it is. I don't know if I can make this happen, but the amount of suction catheter we're going to use, we're not going to use this whole thing. We're only going to use as much as going to be required to get to the underside of this airway. So chances are you are not going to go past lucky 13. I like to put my fingers at 13, so I just make sure I don't go past it. You're going to advance into your airway, advance, advance, advance. And so for this person, my guess is I would stimulate a cough right about 12. So my 13 was on. They're gonna cough, you're gonna suction, 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 right? With your dirty hand, suction, suction, suction. And then for a trach, you need to come out in between suction attempts. You cannot leave this suction catheter in, because that's the only air where they're using. If I was NT suctioning and I hit that sweet spot, I can suction, 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 leave my catheter in, let the patient recover, suction, 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 and then remove my catheter. But for a trach, it needs to come out in between attempts. If your patient has a passe-mur valve, which is a speaking valve, it looks like this, and it goes right on the end of the trach, like that. And if they're on a machine, that would be attached here. Otherwise, we can use the speaking valve just as is. And in case of an emergency, if your patient, you're having issues and you decide, nope, they're not breathing effectively, if they have a trach, you are not going to use the ambu bag and mask at the oral airway. You are going to take the mask off and you're going to go right on the trach here. And you're going to, you're going to bag like this, because that air is moving in and out, pretend, here, right? We're not using this upper airway. So you need, if an emergency, you are going to ventilate your trachs at the tracheal airway site. And that's it. Thanks, guys.